All right. Hello, everyone. My name is Beverly Udebi. Good morning, good afternoon, good evening, whichever time zone you're in. Thank you so much for coming out to this session and coming to the Black Maternal Health Conference. And I hope that this has been a really beneficial day for you guys. So we're just going to get started. So again, my name is Beverly Debbie. I'm a sophomore at Tufts University, majoring in community health on the pre-med track and minoring in Spanish. And I'm also part of the Mother Lab and a volunteer/coordinator for the Black Maternal Health Conference. And today we have Jenny Joseph as our featured speaker. Jenny Joseph is a British trained midwife who fights to ensure every person has their healthiest possible pregnancy, birth, and postpartum experience with dignity and support. Jenny created the JJ Way, which is an evidence-based maternity care model delivering readily accessible, patient-centered, culturally congruent care to women in areas that she terms maternal-toxic zones. So her focus and drive is to ensure that Black women and other marginalized people remain safe and empowered inside these broken and inequitable maternity health systems that have become dangerous and all too often lethal for a lot of women. She is the executive director of her own nonprofit corporation called Common Sense Childbirth Incorporated, which operates a training institute, health clinics, and a birthing center in Orlando, Florida. And she is also the founder of the National Perinatal Task Force, which is a grassroots organization whose mission is the elimination of racial disparities in maternal child health in the United States. In July 2020, her school, Common Sense Childbirth School of Midwifery, became the first and only privately owned, nationally accredited midwifery school owned by a Black woman in the United States. So that's a huge feat. And Jenny is the founder and a proud member of the Council of Midwifery Elders, and she serves on the advisory council for the Congressional Black Maternal Health Conference and is a fellow of the Aspen Institute. So very qualified, and thank you so much for speaking today.
Thank you so much. I appreciate that introduction, and thank you for the invitation to be here and to speak to everybody today. I am so moved, I'm touched, I'm grateful that we are centering doulas. And, I'm speaking often as a midwife, that's who I am, that's what I do. But I'm also keen to broaden the workforce. And when we talk about maternal toxic zones, and I'll share a little bit about that as I go through my presentation today, that's where the doulas are. They are deeply embedded in the maternal toxic zones. So again, thank you, Tufts, for having me, and I'm glad to speak to you guys today. Let's have a run through this presentation. Oops, okay, hold on. I can get my slides to, there we go. So this is me back in the day. I started midwifery. I was a hospital trained midwife in London. I was all excited about birth. I'm still excited about birth. This is my 40th year in the work. And I've been in Orlando for 31 years now. And so I arrived as a midwife to the United States, and I was ready to go. I was looking for work. I went to the hospitals and everybody laughed. They were like, no, we don't do that here. That was a big blow. I hadn't done any research. I hadn't got any clue. Found myself kind of stuck with, well, now what? Because I had only been a midwife for, my entire adult life at that point. I was 30 years old. So I found a way. I started doing home birth. I expanded into birth center work. I'm still running birth centers. I have a clinic and so on. But what I had to do was reinvent midwifery in my world. It was just an odd experience. And that was because I didn't know or understand the history. I also didn't know what a doula was. I didn't know anything about that. So in the journey to figuring things out, because my passion and my mission and my work is about reducing and eliminating disparities, particularly for Black women, people of color, I had to kind of get over myself as a midwife and figure out what else can I do? What else is possible? How can we get this work done? And it became about safety, because the disparities, the statistics, they were wretched and miserable from the time I got here. They're actually the same. Sometimes they're even worse, even now, 31 years later. And we have not got a real strong approach on a public health level on how to fix this. But I was honored to be featured in the New York Times, where they talked about, you know, my model and how it makes pregnancy safer for women of color. I practice as a midwife even now. I'm a Florida licensed midwife. I provide out-of-hospital birth support in a birth center environment. And I put this picture here. This slide is of a woman who was actually at my birth center attempting a birth center birth and had had 2 birth center births with me previously with other children. But this baby, and you can't really tell underneath that blanket there, but that's a big old heifer lump. And we were making no progress at the birth center, so we decided to come into the hospital. We made that transfer from the birth center, and you can see by this picture, look at that end result. Look at that mother's face, look at the nurse's face, dad's standing right there. I get to be part of the support team as a doula now because I'm not operating as a midwife in this instance because I made the transfer to the hospital for the delivery of this baby. And what's really significant about this is, yeah, this is what we're all about. Mama-centered, mother-baby pair, family-centered, supported, empowered birth. I wish this were the picture every time. I wish this were the situation every time. I've been blessed after many years of working in my community to be able to build strong relationships and to be able to work collaboratively. But it took 20 years to get that relationship built up. And it paid off for this mama. She got her birth. Someone else would have cut her. She would have had a cesarean. So technically speaking, our problems are based around the fact that our babies are dying, being born too soon, too small, too sick. And, you know, of course, we're now talking more about the fact that women are dying as well. This is really, to me, a sort of like an almost afterthought. These last few years, we've gotten very clear about, oh, it's about maternal morbidity and maternal mortality. Yes, it is. Well, why do you think the babies were dying? Why do you think the babies were being born premature? Because the mother was suffering. So finally, we put 2 and 2 together and recognize that the women are needing to be attended to and supported like we are, you know, we should be obliged. This is a human right, that this should be a maternal health right, and maternal justice. This is about justice work, because at the end of the day, these statistics haven't changed. If anything, they are worsening, and we all know them. There isn't anybody who doesn't know these statistics who's interested in the perinatal field. So when we talk about deaths and morbidity, please know that we also aren't talking as much as we should about those who didn't die, but nearly died. Those near misses, which I see different statistics, sometimes 50,000, sometimes 60,000. I'm here to say it's probably 200,000. Women don't share their stories. Women aren't even being asked. You survived it, but you might not be able to share that with anybody. You just get on with your life, do the best you can. Near miss is an absolute egregious shame for this nation. And so we've had various solutions that pop up and ways of addressing this. We are all familiar with the social determinants of health. Oh, well, you know, that's why. Of course, she's from such and so zip code, or this neighborhood is full of crime, and of course she's going to have a poor outcome. And those areas I've now named maternotoxic. These are environmental toxicity, meaning the mother or her family, her young children, they're not safe in those environments. Yes, that's true. But let's talk about something else. I talk about what I call pop-up maternotoxicity. Okay, back to that mama that I just showed you in the hospital there. This is her before she delivered her big old chunky baby, right? We had just arrived. She's getting some oxygen, as you can see. She's getting set up ready for this delivery. She delivered vaginally, as you also saw. And you know what? How amazing is this? But the nurse that was on that night was a member of her church. So they actually knew each other. And so nurse was immediately in the doula role. I was already in the doula role. And we know that the difference for this transfer was made in that she was able to feel safe and comfortable throughout. Let's talk about this mama. I want to share her story because it's a different version of the similar thing. Because as I said at the beginning, doulas are operating in every space, in every maternotoxic space, when they're providing community care. Community-based doulas are operating differently to your average maybe labor doula or postpartum doula. Community-based doulas cover every area. So this mama was actually in my clinic getting her prenatal visit, and she had been waiting a minute to get into the exam room. And when I brought her in, she had a look on her face, and I was like, "What's going on, girl? You okay?" And she said, "I feel like, I don't know, I feel all out of sorts, and I couldn't sleep last night." And I get her on the exam table and check her cervix. She's 8 centimeters dilated. So at that point, we're like, "Oh, we better get out of here. This baby's coming." So we called 911, and of course she gets into the ambulance. And I said, "You know what? I'm gonna have to go with her, because we are not gonna put this woman and just send her down to the hospital on her own." I get in the back of the ambulance with her. Before we get around the corner, oh, here's the baby. Because that's what happens. Babies come out, right? Physiological birth. So you can see in the first slide, in the first picture, baby's just out, and I've got baby skin to skin, and mom's looking like, what on earth happened, right? And as we get to where we're going, we had a 10-minute ride to the hospital. You can see now that mom is settling. She's got the baby, baby's pinking out, baby's looking fine, mom's doing great. Shouldn't be any problem, right? We're good. We got to the hospital. Oh no, the circus begins because we got to the hospital. Again, I'm showing pictures of the baby because I really want you to understand the trajectory of how this went. So first thing is, it's a big old kerfuffle because we're coming in the door with the baby already born. We're at the triage and everybody's all looking like aghast because what do you mean the baby's out? So the running begins. You know, the residents are running and the nurses are running and the attending is what happened, and everybody's all trying to figure it out. Meantime, mom and baby are happy in their mother-baby bonding, and you see the beginning changes. Look at mom's face now. She's really coming into her own. She's getting comfortable, and baby starts that little routine that they do, right? Looking for the nipple, beginning to get situated. So long story short, nothing wrong here. The placenta's still in. There was a little bit of a debacle about who was going to deliver the placenta because that's an important thing in the hospital environment. But meantime, this mama baby pair are doing great. I was with this mom because I came in via ambulance, but one of my doulas followed by car. And so she was able to get into the room at the triage department. They let her in because I was already there and because she was with my team. So I was ready to go back to the clinic to finish my prenatals for the day. And I left the doula with the mama. And when I left, the doula was ready to go upstairs and help mother room in the postpartum because, obviously there was no need to go to labor and delivery. When I left, everyone had a new idea around that. And someone decided that she should actually go to labor and delivery. She had delivered the placenta in the triage. My doula was not allowed to go up to the labor and delivery. And here's the point that I'm trying to make about this story. When she got upstairs, the nurse asked, "Do you want to breastfeed?" And she said, "Yes." And the nurse said, "Well, I've got to feed the baby now because the baby was born outside of the hospital." Took the baby and bottle fed that baby in the labor and delivery room. So the reception and the lack of support and protection that was not afforded to her because the doula wasn't allowed into the room. I had left because I inadvertently assumed the doula would be able to continue through to help this mother get to the end of this episode of having a baby in an ambulance and doing perfectly well. Her wish to have a breastfeeding experience was impeded. She had to struggle to breastfeed her child, and this one didn't actually take to the breast and is bottle feeding now. That's the impact of doulas. That's what can happen just that quick, depending on who you are and how you are. We've had study after study after study. This is the first study that was able to show qualitative and quantitative data that people of color experience more mistreatment in birth. In fact, 1 in 6. This study was out of British Columbia with the Birthplace Lab. Professor Vidam and team had been able to put this together to show us that 1 in 6 American women, I'm talking about, being shouted at, scolded, healthcare providers ignoring them, failing to respond to their requests. Top 4 types of mistreatment in the United States. And this is only talking about the labor and delivery. At the end of the day, let's look at the entire prenatal course. Let's look at the postpartum course. Let's look at what's going on throughout this nation, where I believe we apply maternotoxic environments, maybe inadvertently. I'm not trying to cast anybody into a place of wickedness or nefarious thinking or scheming to cause harm. But unfortunately, we have to come to the reality that what we have as a maternal child health system is not necessarily a safe system, is not conducive to the best possible outcomes for everybody. The equity is missing, and maternotoxicity pops up anywhere. So we've worked our model in Orlando for many years now. I called it the JJ Way. It's simply a system where we're looking at centering mother-baby family. And we're also looking at how can we create a culture and environment that supports everybody and is safe for everybody all the time, every person, every time. Based on the fundamental premise, everybody wants a healthy baby. Like, who doesn't? Like, do we know anybody who gets pregnant and then decides that, oh, I don't really care how it turns out? We have to be more willing and able to do the work to address the harms and the toxicity inside of our systems so that we get this every time. This is one of our postpartum groups. Look at the thighs on these children. Do you see these rolls of fat? These are breastfed, happy, healthy babies. Look at the mamas. It's not impossible. It's doable. Some of our stats, we started doing our studies in 2006. We were very blessed with the very first study we did. We enrolled 100 women prospectively from the Easy Access Clinic. These were women who were planning hospital birth, who chose hospital birth, but wanted to have clinic care with the midwives and the doulas. And what we found was in this group, 100 enrolled, not one Black or Hispanic woman had a preterm baby. And this was a comparison to the same demographic of folk who in the Orange County, Florida area were having a 20% prematurity rate if they were Black, 15% if they were Latina. There were none. We weren't doing anything fancy. We didn't have any great number of resources, no obstetric shenanigans, just straightforward care, just straightforward being with women, meeting them where they were, standing with them all the time. This is the work that doulas do. This is how we operate. And when I add midwifery to it, it's just a clinical aspect of doing doula work. At the end of the day, anybody can doula, anybody can midwife. But look what you get when you make sure to incorporate this intervention into care. Not one low birth weight or premature infant was born to an African American or Hispanic woman in the study. 95% of the babies weighed an average 7.5 pounds. 95% of the women delivered at 39 weeks. Huh. These are pictures of the women from the clinic that we made a coffee table book back in 2008, long time ago now, but we just wanted to capture pictures of everyday women from around the way. These aren't models. These aren't airbrushed. This woman, I'll never forget her. I was a doula for her at the hospital. She needed a cesarean, and I can remember it to this day. She told them, I can feel it. And they said, no, you can't. She kept telling them. She cried through the entire surgery. Nobody did anything to mitigate her pain. I sat there useless while she suffered. One of our teen moms. See, we love chunky babies. That's what we do. And what we found is that in order to get these results, we must incorporate an interdisciplinary team. This is not about midwife-centric or physician-centric. We have to work together. These are some of the staff at the Easy Access Clinic. June is a doula, peer educator, resource lady, grandma. She's everybody and everything. Megan started with me as a birth assistant and is now a nurse practitioner. Katrina is a medical assistant. She's been with me 15 years, and she can run my clinic single-handed, because what we're doing in the clinic, yeah, we do a limited clinical care, but we're doing the wraparound, the social support, the listening, the sharing, the bonding. And here's Alexis, also medical assistant. This is one of our doulas in the waiting room. We do waiting room support. While you're waiting, you can talk, we can share, we can do class, we've got resources. There's more to this than poking the belly and listening to the heartbeat. Another study we did in 2014, this is the one where we were able to match pairs. We matched same demographic, same zip code, same receiving prenatal care. We worked with the statistics from the Florida Department of Health, and we came out statistically significant for gestational age and birth weight once again. The way we get this done is we provide access, unimpeded access. We triage everybody, whether it's financial triage, Medicaid, insurance triage, resource triage, social support triage. What do you need, sis? Triage. And then we do our work. And when we give access in that way, we get the connections. Once we connect with the moms and the families, when the families feel they can trust, they start connecting to their baby. The women that are scared to connect to their baby in case of a loss, they calm down, they bond. Everybody's on the same page, and now we can exchange some knowledge. And in the exchange of that knowledge comes the empowerment, and in the empowerment comes the outcome. It just seems pretty straightforward when you look at it from this angle. These are the other factors and interventions that seem to make the difference. These were not afforded to people that suffered in pregnancy, famous people. Serena Williams had to fend for herself. She had to fight for herself. Kira Johnson didn't make it. She's lost. Shaylon Irving is lost. Sometimes it's like there aren't any words because there's a solution here. There's been a solution here. And for Tufts to center doulas in the way that you have today means so much because it's an acknowledgement and a nod to what's missing and how we must be in action towards solving this because we already know exactly what to do. So what do we need? Yes, we need safe space, we need quality space, we need appropriate providers with some cultural humility, willing to acknowledge what's really the root causes, what are the true barriers, and to then be willing to collaborate with other interdisciplinary providers and provide access to those providers and allow families to make their own choices about where they want to be, where they feel safe, how they want to have their experiences. But the providers need help too. We need help to understand each other, to work together, to break down these silos, to stop judging and blaming each other for these inbuilt and historical structural harms, the disconnects that we are so caught up in trying to just paper over these cracks and trying to make it work. No, we break it down and we rebuild it. But providers need support to be able to get there. We need access to being in community with each other. We need to have more conferences like this. We need to work more collaboratively. And then the students need access to training and scholarships and grants. They need certification. They need being incorporated into the payer system. We need to stop messing around with, oh, well, let's see if we can give them a few pennies from Medicaid to do this life-saving and essential work. That has to stop. So yeah, we start training early. There's our Issa. She used to love to measure the belly. These solutions that we're proposing basically are community-based, community-led. The perinatal providers that are already out there and the practices that are already out there, they work. We need to incorporate the doulas, lactation, the community health workers, the medical assistants, and the midwives, because they're protective in all the maternotoxic zones and situations. And we need to create teams to continue this care. So my hope, my goal, I know so many of you that are listening and so many of you are working in this space are already here, is that we build and we support a pipeline of community-based and diverse practitioners and sustainable practices, and that we do our part to make sure the sustainability is built in. Because at the end of the day, it's a matter of life and death. This is what we need. We need access, connection, knowledge, and empowerment towards changing this miserable situation once and for all. So I'm not sure how I am with time, but if we have time, I'd love to take questions if there are any. And also, I just want to really thank you for the opportunity to share today.
Good afternoon, everyone. We do have an amazing amount of questions. I am going to read them off. I did not collect who wrote them, but they will know which questions they wrote. So the first one says, is it typically better to choose a birthing clinic near a hospital?
Well, there's always a relationship between if there's a complication during the birthing process, that if you need to transfer to the hospital, the sooner you get there, the better, obviously. But women that are people that are chosen for a birth center birth and, who want that, but also have an assistant, whether midwife, provider, medical provider, there has to be screening. Not everybody is safe in a birth center environment if they have complications. So it really comes down to not so much the proximity to the hospital, but rather, are you being seen at a place where they're taking good care to give you quality vetting and support in maintaining enough health to be eligible for birth center birth. Out of hospital birth has its place, but we're talking about safety after all. And it's not conducive to safety if you have high blood pressure, diabetes, or some other ill comorbidity, and then you're also trying to birth in an out-of-hospital environment. That's not a good idea.
Thank you. The next question is, what are ways doulas can provide support and advocacy during births in which a cesarean delivery is required?
Right. Ooh. If we know it's going to be cesarean, it's important to make the birth plan around that cesarean. And so as best you can, it's really important to have a set of questions already prepared so that there's an opportunity to have some provider give a real solid answer to each of the questions, and that we don't accept any sort of shushing or patting on the head of, no, don't worry about that. We are worried about whatever we're worried about, and we must have an opportunity to ask those questions. So is it, for example, a possibility of immediate skin to skin with the baby, or will the baby go to the baby warmer? So really breaking down, almost reverse engineering the process of having the cesarean and how the family can interact with that process at every step of the process. I talked about the young woman who was ignored when she felt pain. We need to have a question on the table before you even go down to the OR. If I feel pain, what is going to happen? What are you going to do about it? So preempting possibilities, exploring possibilities, and getting the questions out, but also having the answers, the acceptable answers ready right away is the way to prepare for a planned or a scheduled C-section.
Perfect. So the next question that we have is, since the JJ Way is research-backed and assumably provides reproducible results, why do you feel like it has not been adopted across the board or by other practices?
Oh my goodness. I have a lot to say about that. I think one of the main reasons is because it's so considered to be so outside of the norm. There's people who immediately get caught up with, oh, it's a midwifery model. Well, midwifery. No, it's not a midwifery model. It's a patient-centered model. It's a human rights model. It's a maternal justice model. So there's a misunderstanding about what it is. There's another piece. Oh, well, if we fix this problem, then what are we going to do? The whole problem is not actually an accident. There is a way that we do commercial medical care, and that involves harms that sometimes harm more people than some people more than others. So in terms of fixing, what are we actually fixing? So this model is a community-based and a community-embedded model and needs to be supported from that stance. That's not easy for everybody. Folk want to put these solutions all in the hospital space or in the medical space. They don't always belong there. That's why doulas aren't adopted either. When we put the doula solution on the table, we come up with every excuse under the sun as to why, well, we can't pay that much, or we can't do this, well, no, we can, but we don't want to. So I'm just gonna say, I believe a lot of it is based on, no, we just don't want to adopt this model because really it's too simple. Like it works and it's cheap and mid-level and other paraprofessionals can do it. Oh, hang on, let's think about that. I'm sorry to be cynical. I'm a bit emotional today. So that might be some of the reasons. I don't know if that's every single reason why it's not accepted
It's
or
totally
replicated.
fine. So we do have questions that are rolling in, and I do want to let the participants know that if we do not get to it within this moment, we will pass them on to Dr. Joseph, or excuse me, Miss Jenny, who will be able to provide you with any additional details at a Q&A session we're going to have later on, or a networking session. The next question that I do want to bring in, because I'm going to maybe ask two more and then we're going to end the session because we're coming close to time, is what advice do you have for young Black college students interested in pursuing midwifery and doing Black maternal health research?
Well, absolutely do both of those things. Please, we so need you. One of the biggest obstacles we have is the shortage of the workforce. So doing the research helps inform you as to what's wrong and how we need to address it and what's going to work towards addressing it. Being a midwife puts you in action in terms of physically being able to be part of the solution, getting your relationships with the mothers and families, putting your hands on mothers and babies. Mama Shafia hit the nail on the head. We want to touch and share and be connected to our communities. Midwifery is an access point to that ability to be in community, to touch, to support, to be there. Doula work is a stepping stone to midwifery as well. So I encourage anybody who's interested in this field. And usually if you are interested in this field, you're actually called to this field. Like, you don't have any option. You can't get away from that. It will keep coming. No matter how many different roads you try to take, you will find yourself back here because it's inside of you. It's a calling. And just like the grand midwives of old, they answered that call. And in their day, they did it the way they did it. We're up against these obstacles in this day, so we're going to have to do it this way. But I encourage anybody who has that in their heart, in their spirit, in the passion for helping, and you feel like you can do it in this field, please come on, we need you so badly.
Well, Jenny, I want to thank you again for your service and your time. We are wrapping up. I invite all participants to log into the next session, which is the closing segment of this wonderful, amazing conference we've been holding all day. So I look forward to seeing you guys. We'll make sure we get these questions answered and put out in the app for you guys. Have a great afternoon.
Thank you, everybody. Bye-bye.